We'll have questions after this next session. We have Dr. Anna Paul from Medicine 2, who will be doing a critical appraisal of cohort in endocrinology. Questions will be after this session. And as mentioned before, we will be taking questions which are online or posted on the Google.
Good morning. I'll be doing a critical appraisal of the PURE study using the CASP questionnaire. So I'm going to start with the case. This is a 37-year-old Mr. X, comes to your OPD for a general checkup. His diet predominantly consists of high glycemic index food, but he's otherwise active and has no family history of type 2 diabetes. He wants to know what his risk of developing diabetes in the future is and if he needs to change his diet. So this question I'm going to address using the PURE study, which is a prospective cohort study that looked at the association of glycemic index and glycemic load with risk of type 2 diabetes. This was published in April 2024 in Lancet Diabetes and Endocrinology. I'm using the CASP questionnaire, which is an online free tool to appraise the cohort study. There are other tools like the JAMA critical appraisal tools, but those are paid tools. So the first section of the CASP questionnaire is, are the results valid, or was the study methodologically sound? So did the study address a clearly focused question? So the CASP questionnaire actually gives you some questions that you need to look at to answer the questions, but in the interest of time, I will not be going through them. So for this question, I said yes, because the main question addressed here is the PICO of your study. And in this study, the population was adults aged 35 to 70 from high, middle, and low income countries. The exposure that they were looking at was glycemic index and glycemic load. So they compared high glycemic index versus low glycemic index. And the outcome of interest here was the incidence of type 2 diabetes. They followed up patients for a median duration of 11.8 years with an interquartile range of 9 to 13 years. So the next question was the cohort recruited in an acceptable way? For this, I said yes as well. This is a prospectively recruited cohort. They had initially included around 186,000 individuals between the age of 35 and 70 years of age. Again, like I mentioned, they have taken low, middle, high income countries. They've made sure they've taken both rural and urban and various different communities within each of the different countries, and was quite representative. The next question is, was the exposure accurately measured to minimize bias? Again, I gave them a yes for this. The exposure that they were looking at was the glycemic index, whether it was a high glycemic index or glycemic load. They assessed this using a baseline questionnaire, which was country-specific, validated food frequency questionnaires for all the patients who participated. And they categorized the food into 7 categories of carbohydrate-containing food. And they use this based on international glycemic index tables and databases for tropical food. And they've mentioned where they didn't have standardized questionnaires, they have looked at region-specific and created their own tools. And all of the details of this is given in their supplementary material. The glycemic load was calculated using the glycemic index. So I believe they've done a good job at accurately measuring the exposure. The next question is, was the outcome accurately measured to minimize bias? So the outcome they were looking at is incidence of type 2 diabetes. And type 2 diabetes was diagnosed if a patient was diagnosed by a physician. They were started on OHAs or insulin, and they've documented a fasting glucose level of 126 or more during follow-ups. And these patients were all followed up at least once in 3 years over the 10 to 11-year follow-up period. The subjects and the outcome assessors were not blinded, but I still said yes to minimize bias because while it's not death, it's still the incidence of type 2 diabetes is a fairly hard outcome. So I have said yes for outcome measures. The next question is, have the authors identified all important confounding factors? Have they accounted for the confounding factors in the design or the analysis? So based on the talk we just had and what we all know, there are multiple factors that contribute to type 2 diabetes. So your BMI, genetic, where you come from, family history of diabetes, all of these are contributing factors. So this is their baseline characteristic table. So they have actually divided patients into 5 groups or quintiles based on their glycemic index. So Q1, which is quintile 1, had the lowest glycemic index, and Q5 had the highest glycemic index. So if you look at it, like when you look at urban residency was much higher in quintile 1 as compared to quintile 5. Family history of diabetes, blood pressure medication, again, was more in quintile 1, whereas the quintile 5 patients were mostly from South Asia and China, whereas quintile 1, that's the low glycemic index, was more concentrated in Northern America and Europe. So there were significant differences that could contribute to the incidence of diabetes among the quintiles, even in terms of their dietary factors. However, they have accounted for this in their analysis. So they have, their primary outcome was a hazard ratio, for which they did a multivariable shared fragility Cox regression model, which is accounted for variability between clustering, so between countries and sites. And they have also done statistical modeling, where they've accounted for factors that may contribute to incidence of diabetes. So they've done model 1, model 2, model 3. So age, sex, urban, rural location, history of diabetes, daily energy use, fiber intake, all of this was modeled or accounted for in their modeling. So I think they have done a good job at accounting for the confounding factors, and they've taken it into account during their analysis. Was the follow-up of subjects complete enough? Was the follow-up of subjects long enough? Again, for this, I said yes. Their median duration of follow-up was around 11.8 years, with an interquartile range of 9 to 13, which is a fairly decent amount of time to follow up for new incidents of type 2 diabetes. If they had followed up for longer, it would have been great, but practically that might not have been possible. They've also mentioned that 9.3% of the participants died, and they had less than 1% follow-up, but these patients were censored in their hazard ratio calculation. They've also mentioned that they did 10 rounds of imputations for values that were missing in their analysis, like demographic, lifestyle. If that value was missing, they have done imputation, and they've done multiple rounds of it for analysis. They have also reported a complete case analysis, which means they've excluded all patients who had data missing and included only those who had data in their analysis. So now that I think that the study was methodologically sound, we'll go on to section B, which is what are the results. So they did not have a strobe flowchart, but in their write-up, they have mentioned that of the 186,000 odd patients, they had data on glycemic index and glycemic load available for 145 patients. They excluded participants with implausible energies. So based on the questionnaire, if someone's glycemic index was extremely low or extremely high, they assumed that it was an error because it was an implausible energy, and those patients were also excluded. And those with baseline diabetes were excluded. So totally they had 127,594 participants without any known history of diabetes who were included in this study. And like I mentioned before, the participants were categorized into quintiles based on their glycemic index and glycemic load. So this is their main results table. So again, quintile 1 had the lowest glycemic index, and quintile 5 had the highest glycemic index. So in quintile 1, people with diabetes, there was a 6.6% incidence, and quintile 5 was 4.7. Then they have done their modeling. So model 1, model 2, model 3, and model 3 is the one that had accounted for the most number of things. So family history of diabetes, BMI, waist to hip ratio, all of that, and their other dietary protein intake was all accounted for in model 3. And so only in model 3, looking at quintile 4 and quintile 5, they found a hazard ratio that was significant. So they got a 1.15 hazard ratio with a confidence interval of 1.03 to 1.29. All the other confidence intervals were crossing 1, therefore were not statistically significant. They had similar findings in the glycemic load, which is mentioned below. Like I mentioned earlier, they did a complete case analysis. That means only patients who had all the data available They had around 1 lakh patients of this, and they had similar findings again. So only in model 3 was it statistically significant, with a hazard ratio of 1.21, with a confidence interval of 1.06 to 1.38. They've also compared low BMI versus high BMI. And in the higher BMI group, quintile 5 versus quintile 1 showed a higher glycemic index is associated with a higher incidence of type 2 diabetes. This is an interesting part of the study which they did, which is not part of the main article, but was present only in their supplementary material. But they've done a random effects meta-analysis to include the results of the pure study to that of a previously done meta-analysis by Reynolds et al. So all of this is from the previous meta-analysis, and they've added the pure study results to it and given a pooled result. So if you see based on this forest plot, the pooled results, including the pure study to the previous meta-analysis, showed that a higher glycemic index diet was associated with higher incidence of type 2 diabetes. The next question is, how precise are the results? So the precision is based on the confidence interval. They have reported a confidence interval, which was from 1.03 to 1.29, which I think is quite a wide confidence interval. So do you believe the results? So for this, unfortunately, I said no, because one, the hazard ratio was only 1.15, which means only a 15% increase. And the confidence interval was quite wide, ranging from 3% to 29%. And you will notice that the effect was not consistent across the models. So only in model 3, in quintile 5 alone, was it slightly increased. Therefore, I don't believe the results. The last section is, will the results help locally? So can the results be applied to the local population? Yes, they have included Indian patients. And they have also mentioned they had region-specific validated questionnaires for India. I think they had included around 9 different regions. And the final question is, what are the implications of this study for practice? So the question is, what should Mr. X do? So based on the pure study alone, there wasn't enough robust data or the association was not strong enough to say that high glycemic index does cause type 2 diabetes, but there was definitely a trend. And based on the meta-analysis that they've done, seems to suggest that there is a higher incidence. So for Mr. X, maybe I would advise him that he has a slightly higher risk and there's no harm in changing his diet, but I would not change any national policies based on the pure study. Thank you. Again, I'd like to remind the audience that the Q&A section is online, so please answer using the ask your questions using the QR codes. Thank you.